Yeah, our next speaker, Stewart speaker, will be talking about supracondylar fractures.
Right, good afternoon. It's very welcome to see so many people in a pediatric session. I think this is the start of, I'm going to be speaking about supracondylar fractures. They are within the group of fractures around the elbow the most common, and it's probably important to know a little bit about them. Like Fahi, here's my declaration slide. Nothing, unfortunately. The epidemiology, they constitute about 3/4 of all elbow injuries in children. Boys traditionally more than girls, but in fact that gap is closing. And for reasons that Fahi alluded to, peak age of between 5 and 8 years, and after that the fracture patterns start changing, tending towards dislocations. Usually the left non-dominant hand. Makes sense to me that you would be holding on as tightly as possible to whatever does you're falling out of, and use your non-dominant hand to break your fall. The nerve injuries quoted anywhere between 7 and 20%, and vascular injuries in about 0.5%. So the reason that you break at this age is that you have remodeling between 5 and 8 years of age, a decreased AP diameter. There's ligamentous laxity, but at the back end of this ligamentous laxity is a very thick anterior capsule, creating a strong fulcrum about which one might be breaking in a hyperextension injury. The periosteal hinge, and these are usually extension injuries, at the back, usually intact, and we're going to use that in our reduction. The mechanism, by far the majority are going to be hyperextension injuries. We see very few flexion injuries, and I'll talk a little bit about them. To fall on an outstretched hand, plus minus a varus valgus force, and according to that varus valgus, one would get posteromedial or posterolateral displacement. The rule about the flexion injuries is they usually direct blows. The displacement is going to be anterior rather than posterior, and the rule is that if you're struggling in theatre at 2 o'clock in the morning with an apparently irreducible supracondylar fracture, it is that 1 in 50 odd that are flexion injuries. Clinically, they're swollen, they're globally swollen, in contrast to the lateral condyle. There might be a pucker with that small fragment of bone trapping the skin, and a neurovascular exam prior to going to theatre is vital. There are certainly iatrogenic injuries that are going to be caused by going to pin these, and it's important to know that the injury was present prior to getting to theatre. And then just briefly, the tests for nerve function, make a fist, OK, and star sign just to exclude median, radial, and ulnar palsies. So here's one classification that may well be useful in pediatric elbows. It's a Gartland. The undisplaced is a 1. The displaced with an intact bony hinge is going to be a 2, and that is completely displaced is going to be a 3. But even within the 2, there definitely is a subgroup that despite the fact that there's a hinge, they either become unstable in theatre or they have been inherently unstable before. And in my head, I'm then push them into the group of the 3. What's the basic treatment? Well, the Gartland one, which is undisplaced, can be safely treated in either a simple collar and cuff with the hand pointed towards the contralateral shoulder, or in a collar and cuff plus a back slab, which is our preference, but I think that either is valid. We then discharge the patient once we are satisfied that there isn't a compartment syndrome, bring them back in 3 weeks' time, we remove the back slab, and we do not at that stage re-x-ray. And so that treatment is fairly clear. What do we do for the Gartland 2s? Well, we know that they are displaced. This fracture is displaced posteriorly here. We've lost the normal anteriohumeral line, which should pass through, transect the capitellum. And so these and we also know that AP posterior translation is not going to remodel well. So these ones we will take to theatre. We will usually just flex them in theatre, gain reduction, restore the alignment to the anteriohumeral line, and then place them back into back slab as in A1. If they become unstable, we're going to go on to the treatment of the Gartland 3, which is book them for theatre, scrub and drape, manipulate, and I'll speak about that a little bit now, and then various configurations of KY placement. What are we going to do at 2 in the morning, having been faced with the irreducible Gartland 3? Some authors would advocate open reduction, and I think that this is perfectly appropriate. At times, we in our institution have used this. The original Dunlop traction reported here by Kerr Graham. It's an easy way late at night to get out of trouble. It avoids the stiffness that often follows open reduction. And in fact, we have gone on to treat patients like this to completion. Now, the reduction concept. There's a couple of steps that need to be followed fairly carefully. We will start with longitudinal inline traction. It's the one place you're going to get your revenge on an anaesthetist who has to then hold onto the patient to prevent them being pulled off the bed. Try and keep your back straight and the anaesthetist's back bent, just to really drive home the message. 10 minutes. Look at the clock. It's 10 minutes of doing nothing but pulling is a long time in theatre. We then hyperextend the elbow to try and obtain apposition. Having gained that catch, we would then, in a first coronal and horizontal planes, and then sagittal planes, reduce the fracture. Thereafter, flexion of the elbow, and we usually at this point pronate it, which locks the fragment in. And our registrars then will use elastoplast to maintain that reduction so that it frees up their hands. After our sisters are very reluctant to touch patients. And then we'll talk a little bit about pins, but our preference at the moment is lateral pins, 1 medial if necessary. And that's just the steps: traction, coronal, sagittal, and axial planes. The flexion types, I've already said that we are mobilized in a long arm cast, 3 weeks. The type 2s, we're going to usually close reduction and pinning. In the type 3s, where reduction may be difficult, we may need ORIF or Dunlop traction. What are the controversies? And this is really the part that I wanted to speak a little bit about in this talk. They surround the vascular injuries, wire numbers and placement, and neurological injuries. So, vascular injuries. In almost a fifth of grade 3 supracondylar fractures, and probably more where some of us come from where the referral patterns are not as good, we have an absent pulse. And what not to do with this? It's relatively controversy-free. I'll go with what most people would suggest. You need to clinically evaluate perfusion, color, warmth, capillary refill. There's no place at this point in arteriography. If you're going to make the decision to go to theatre, then that's going to be a vascular approach, and you're going to need to see the vessels. But in the acute setting, there's consensus that arteriography is going to be excluded. What are we going to do? We're going to reduce this elbow first. Having done that, reevaluate. And if the pulse at that point is still absent, then one is faced with a decision as to whether or not to take anything further. So if at that stage we find evidence on Doppler that there is no distal pulse, then Shaw and Schunecker proceeded and they found that there were no false positives with Doppler. And they went on to do vascular repair. And I can't argue that, except that Sabowal went back and had a look at the actual fate of those vessels. And in fact, a very high proportion of them re-occluded. making the initial decision to open them up null and void. You need to make up your own minds. I can't say, but what I can say is that our own local approach is clinical examination plus minus Doppler. But in general, so long as there is a warm, perfused hand with good capillary refill, we will stop there. We're obviously going to exclude compartment syndrome, but we do not promote routine vascular repair. Wire numbers and pace placement. Well, this has still not gone away. We've been using K-wires for over 50 years. Jones, in one of the original descriptions, says that an average surgeon can manage these with K-wire fixation without complications. Now, I think that all of us have been bitten, and some severely, by supracondylar fractures. So I think that may be a little hopeful. What are the considerations in wire fixation? Well, stability and slip, and iatrogenic ulnar injury. The techniques, they can be crossed. We do know that we are going to have an ulnar injury in 8% of patients. We can then add another lateral wire so that the medial wire may be pulled, but you still need to warn the patient that we may be injuring a nerve, and that injury, while it is going to most likely recover, might take some time. And we do think that this approach is more stable. We could use lateral only wires. This comes at the benefit of not damaging nerves, but at the increased risk in some series of slip, and may be related to the position of those wires. The neurological deficit. So we wake up post-theatre and we discover that the patient has a neurological injury. Obviously, if that was not present, and that's why I said it's very important to document what you had before, if it wasn't present prior to theatre and you're confident about that, you're probably going to need to address your pin placement, and then think about your approach to that injury. The anterior interosseous nerve is the most commonly injured, so look for the O sign. And then bear in mind that the direction of the fragments may point to which side, as to what nerve would be injured. So your posteromedial, commonly the radial nerve, posterolateral, the medial, and the flexion type, often the ulnar nerve. The treatment, iatrogenic, pull out that wire. In general, the treatment of nerve injuries in a supracondylar fracture is going to be conservative. And we usually intervene at 2 to 3 months, in particular addressing the perineural fibrosis, which is often the root cause, in which case the patient would need neurolysis, and we do not see the necessity at an early stage for EMGs. So just pragmatically, how are we going to address pin placement? Pragmatically, the stable type 2s we're going to leave alone. For the unstable 2s and all 3s, our current policy, and I can't say that this is the only way to do it, but the current policy is to use 2 lateral pins if the fracture is stable and we're happy about the experience of the surgeon. If we're unhappy about either, so either unstable fracture or new registrar, we're probably going to advocate 3 lateral pins. If 2 lateral or 3 lateral remain unstable, we may add a temporary medial pin, or we may add a pin that is left in place. If the following morning there's an iatrogenic ulnar nerve injury, we'll apologize to the parents, pull out the pin, and monitor. So in summary, this is a common injury. Reduction can be tricky. There are controversies surrounding the management of vascular injuries, wires, and neurological injury. Thank you.
Thank you, Stewart. I know you have to leave, so thank you very much for the excellent talk.